Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal.
In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy.
This episode reviews the article titled Staged Hybrid Coronary Revascularization in a High-Risk Octogenarian, a Care-Compliant Case Report.
To begin our deep dive today, we need to set the stage with a very challenging clinical scenario.
Right. I want you to imagine an incredibly high-stakes medical situation.
Yeah.
An 87-year-old man with a failing heart, diabetes, kidney disease, and severely blocked arteries is rushed into the hospital.
And he's actively having a heart attack.
Exactly. But traditional open heart surgery, which is the usual fix, might not be survivable for him. But doing nothing is fatal. So what is the solution?
It's a profound dilemma. The standard flowchart of cardiac care completely breaks down when a patient's physiological baseline is this compromised.
The mathematical algorithms we use to predict surgical survival just start flashing red.
They absolutely do.
Okay, let's unpack this. For today's deep dive, we are pulling from a fascinating 2026 Care-Compliant Case Report. It was published in the Georgian Medical Journal, authored by Georgian and a team of researchers from New Vision University and Shota Rustaveli State University.
And the mission for this deep dive is to explore a cutting-edge approach they used to save this man's life.
Right, it's a technique called staged hybrid coronary revascularization. And it really is rewriting the rules of what is medically possible for high-risk elderly patients.
It is. But to appreciate the ingenuity of the solution, we first have to understand the sheer magnitude of the biological problem.
So let's look at the patient's profile. He comes in presenting with an NSTEMI.
Which is a non-ST elevation myocardial infarction.
Right. And for those listening who might not be cardiologists, this is different from a sudden, massive, widowmaker heart attack, where the artery completely clogs in an instant.
Yes, in an NSTEMI, the artery isn't 100% blocked, but it is so severely narrowed that blood flow is it's reduced to a trickle.
And the deepest layer of the heart muscle, the subendocardium, is the furthest away from the blood supply. So it begins to suffocate and die first.
Exactly. And when the team rushes him to the catheterization lab to look at his blood vessels on an X-ray, they discover critical two-vessel coronary artery disease.
If you were looking at his angiogram with us right now, you wouldn't just see one blocked pipe. You'd see a system on the brink of total failure.
He has a severe lesion in the left anterior descending artery, the LAD. Plus, he has a significant blockage branching off from that, and another severe narrowing in the middle of his right coronary artery.
But the blockages are only half the battle, really. We have to look at the patient's overall state. He has diabetes, hypertension, dyslipidemia, which is abnormal blood cholesterol, and chronic kidney disease.
And those comorbidities are not just background noise. They actively change the physical texture and function of his internal organs.
How so?
Well, take the diabetes and dyslipidemia, for example. Chronically high blood sugar causes these advanced glycation end products to build up. This chemically cross-links the collagen in the artery walls, making them incredibly stiff.
So they lose their elasticity.
Completely. Over time, calcium deposits form. The arteries literally become calcified. They harden significantly.
And then there's the chronic kidney disease. Kidneys are essentially the body's filtration plants, right?
Right. And if his kidneys are already failing, they cannot easily clear out heavy toxins. That includes the powerful anesthesia required for major surgery or the heavy contrast dyes doctors use for imaging.
His hypertension also means his heart has been pumping against high pressure for decades. The muscle is thick and exhausted.
The original report actually quantifies all of this systemic danger using specific risk metrics. They cite an STS score of 6.6% and a Euroscore 2 of 8.6%.
Single digits sound low to the average person.
Yeah.
But we're talking about algorithms that calculate the probability of mortality, right?
Exactly. In the realm of cardiac surgery, a Euroscore 2 of 8.6% is a massive red flag. It officially categorizes him as having a high operative risk.
So it tells the medical team that if they put this 87-year-old man on an operating table for a standard open heart bypass, the physical trauma of the procedure itself could be fatal.
Yes, it is highly likely to trigger a fatal cascade of organ failure.
Normally, if someone has blocked arteries, you either do a full open heart bypass or you put in stents. Why couldn't they just, do one or the other here?
It's the ultimate catch-22 for frail patients. To do a standard open-heart bypass, the surgeon has to crack the chest open, stop the heart from beating, and route the patient's blood through a heart-lung bypass machine.
And that machine is a miraculous piece of technology, but it is incredibly violent at a microscopic level.
It really is. When human blood comes into contact with the artificial plastic tubing of the machine, the body's immune system panics. It flags the plastic as a massive foreign invader.
Which triggers a flood of inflammatory cytokines.
Right, resulting in systemic inflammatory response syndrome, or SIRS. For an 87-year-old with already failing kidneys, that massive immune overreaction is what actually destroys the organs.
So the plastic tubing triggers inflammation that shuts down the kidneys, not the surgeon's scalpel.
Precisely. The biological toll of the heart-lung machine is simply too high.
Okay, so if the systemic shock of the bypass machine is a fundamental non-starter, my immediate instinct is to pivot entirely to stents.
Percutaneous coronary intervention, or PCI?
Yeah, you just thread a wire up through the wrist, navigate to the heart, inflate a tiny balloon, and leave a little metal mesh tube behind. It's minimally invasive, you don't crack the chest, and you never use a heart-lung machine. Why not just go with that option?
Well, because it creates a mechanical failure point in the most important area of his heart. The LAD supplies the vast majority of blood to the left ventricle, which does the heavy lifting of pumping blood to the entire body.
But wouldn't a metal scaffold be exactly what you need to force open a stiff, calcified pipe?
In a simple soft cholesterol blockage, yes. But biological calcification is jagged, rock-hard, and asymmetrical. When you inflate a high-pressure balloon inside a deeply calcified artery, the stent cannot expand into a perfect uniform cylinder.
Oh, I see. It might leave tiny gaps between the metal struts and the artery wall.
Exactly. And any imperfection in a blood vessel creates turbulence. Blood flow becomes chaotic over those poorly expanded struts, causing platelets to clump together.
Which leads to stent thrombosis, a sudden blood clot forming directly inside the stent.
And that would cause a massive, fatal heart attack down the road. Both standard flow charts lead to a dead end.
So the single procedure approach is just too dangerous. They have to completely rethink the decision-making process.
What's fascinating here is how contemporary medical guidelines are shifting away from solo decision-makers toward a collaborative, risk-adapted approach. They utilized a multidisciplinary heart team.
Right. It's not just one doctor making a call in a vacuum.
Yeah.
You have cardiac surgeons, interventional cardiologists, anesthesiologists, and imaging specialists all collaborating rather than competing.
And the friction between these different disciplines is what breeds innovation. The anesthesiologist says the kidneys can't handle a 6-hour surgery. The cardiologist says the LAD is too calcified for a stent.
And the surgeon says his sternum is too fragile to cut open. So they build a custom strategy, the staged hybrid revascularization.
Exactly.
I like to compare this heart team approach to assembling a master crew for a complex home renovation. If you have a historic house with a fragile foundation but rusting pipes, you have to be careful.
You can't just hand the whole house over to one person.
Right. If you bring in a heavy-duty structural carpenter with jackhammers, the sheer vibration shakes the fragile foundation to pieces. The house collapses.
But if you only use a delicate indoor plumber, they might fix the minor leaks but ignore the massive, load-bearing pipe that is actively rusting through.
Exactly. The heart team strategically deploys both, exactly where they are strongest, to avoid collapsing the frail foundation. They broke the treatment into 2 distinct stages.
So let's look at stage 1, the most critical phase. The goal is to secure that load-bearing pipe, the LAD, using the most durable surgical method known without cracking the chest.
They opted for a procedure called a mid-cab, minimally invasive direct coronary artery bypass. They access the heart through a small left thoracotomy.
Which means they just made a small incision between the ribs on the left side, preserving the structural mechanics of his rib cage.
This is crucial for an 87-year-old. When you crack a sternum, every breath is excruciatingly painful for months. They often fail to take deep breaths, leading to fatal postoperative pneumonia.
By avoiding the sternotomy, they bypassed that entire risk cascade. But here is the challenge. They also had to avoid the heart-lung bypass machine to save his kidneys.
Here's where it gets really interesting. That means they had to physically stitch a tiny, fragile new blood vessel onto the blocked LAD artery while the heart is still actively beating inside his chest.
It sounds like a physiological impossibility. The heart is violently twisting and pumping blood 60 to 80 times a minute.
Trying to sew 2 tiny tubes together with microscopic thread while it's jumping around. It's like trying to thread a needle while riding a roller coaster.
It is. So to solve this kinetic problem, the surgeons use a mechanical tissue stabilizer.
Think of a highly advanced camera gimbal used in action movies. The operator is sprinting, but the gimbal absorbs the kinetic energy so the camera lens stays perfectly still.
The tissue stabilizer does the exact same thing for the surgeon's visual field. It has tiny suction cups that grip just a 1-inch square of the heart muscle.
Just the exact spot where they need to sew.
Right. It holds that single square inch dead still, absorbing the shock, while the rest of the heart continues to pump naturally.
So the patient's kidneys never endure the inflammatory nightmare of the bypass machine. But why go to all this surgical trouble just for one artery? What is so special about this specific graft?
They attached the left internal mammary artery, or lima, to the LAD. The lima naturally runs along the inside of the chest wall.
But why not just use a vein from the leg, like in a standard bypass?
Because the endothelial cells lining the inside of the lima actively secrete nitric oxide. It's a potent vasodilator that keeps the vessel wide open and actively repels platelets.
Oh, wow. So it's essentially a living, self-cleaning pipe.
Exactly. Studies show that even 20 years after surgery, over 90% of Lamitel-led grafts are still flowing perfectly. It's the absolute gold standard for long-term durability.
So securing this major artery first was the absolute priority, and stage 1 was a massive success. But the plumbing is still compromised. He still has a severe blockage in his right coronary artery.
The job isn't done. But this is where the sequencing of the staged hybrid approach becomes crucial. They waited 2 full days before moving to stage 2.
Why intentionally wait 48 hours? Why not just put the stent in while he's already in the operating room?
It all comes back to the kidneys. Placing a stent requires flooding the vascular system with iodine-based contrast dye so the cardiologist can see the wires on an X-ray.
And that contrast dye is heavily nephrotoxic, right?
Yes. The large dye molecules can clog the filtration units in the kidneys, causing acute contrast-induced nephropathy.
So if you combine general anesthesia, surgical trauma, and nephrotoxic dye, all in the exact same afternoon.
The combined biochemical load overwhelms the renal system entirely.
Wow. So by waiting 48 hours, they gave the patient's kidneys time to flush out the anesthesia and stabilize.
Exactly. Only then did they transport him to the catheterization lab for stage 2. The delicate plumber comes in.
The interventional cardiologist threads a wire up to the mid-right coronary artery and places a drug-eluting stent.
A drug-eluting stent is coated with a medication that slowly releases into the artery wall, preventing scar tissue from growing over the metal mesh.
And because the right coronary artery wasn't as heavily calcified as the LAD, the stent was the perfect low-impact tool for that specific blockage.
Both procedures were completed without a single complication. Complete revascularization achieved.
So what does this all mean? I mean, how impressive is the recovery timeline here?
It is truly staggering. This 87-year-old man with diabetes and failing kidneys who arrived with an active heart attack was discharged to go home on postoperative day 5.
Wait, really? Day 5?
Day 5. A traditional open-heart surgery for someone that frail could mean weeks in the ICU on a ventilator, assuming he survived at all.
If we connect this to the bigger picture, the authors emphasize that this approach allowed them to achieve complete revascularization.
Historically, doctors were often forced by a patient's frailty to settle for incomplete revascularization. They would just patch the single worst blockage and deliberately leave the others alone.
Just patching the leakiest pipe to stop the immediate flooding, but leaving a network of failing pipes behind.
And that creates a chronic ischemic burden. Leaving those secondary blockages untreated leaves the patient at a significantly higher risk for subsequent heart attacks and premature death.
This hybrid approach proves that elderly patients can safely get the entire system fixed. Every blocked pipe was opened. That massively improves his long-term prognosis.
It does. It fundamentally alters how we can treat complex cardiovascular disease.
And that is exactly why this deep dive matters for you, the listener. As global populations age, you or your older loved ones are increasingly likely to fall into this high-risk category.
The standard narrative has always whispered that advanced age means you just have to accept compromised treatments.
Right, that you just have to manage the slow decline. But this care-compliant report provides a concrete blueprint showing that advanced age and frailty no longer means settling for halfway treatments.
This raises an important question, though. If this multidisciplinary, staged hybrid approach yields such rapid recoveries and durable results for the most vulnerable patients,
how must global hospital systems structurally and financially reorganize themselves to make the heart team standard practice everywhere, rather than just an exception in specialized centers.
It requires a culture of deep, ego-free collaboration that isn't present in every community hospital yet.
It's a massive structural challenge, but the clinical blueprint is right there in the literature. Thank you for listening to the GMJ podcast.
For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description.
We look forward to continuing these scholarly discussions in future episodes.